Now we're going to talk about intrauterine procedures. Anytime we do a procedure, we want to talk to the patient about the risks. And usually we're going to be thinking about the risks of bleeding, infection, and injury to surrounding tissue. The uterus is very vascular, so there's always some spotting after any intrauterine procedure. And we try to give advice about what to expect in terms of how much spotting that someone would expect afterward. Infection is generally not a big risk because usually we're putting something into the uterus and not leaving anything there. When we're doing an endometrial biopsy, we're taking a sample and then we leave no foreign body behind. So the risk of infection is very low. We do use an antiseptic solution on the cervix to help reduce that risk further. When we are placing an intrauterine device, there is a foreign body left behind. Old IUDs used to be associated with a higher risk of pelvic inflammatory disease, but with the modern IUDs, that is not the case unless somebody has an active infection with gonorrhea or chlamydia at the time that we place the IUD. In that case, we can pass the gonorrhea or chlamydia bacteria into the uterus and then it stays there with the IUD. If the patient does not have an infection at the time that we put the device in, there's no higher risk of getting a pelvic inflammatory infection in the future than there is to someone who doesn't have an IUD. An important concept in preventing infection with intrauterine procedures is what we call no-touch technique. When using no-touch technique, we actually don't even need to use sterile gloves. We only touch the handles of the instruments that will be on the outside of the patient. We never use our gloves to touch anything that will actually touch the cervix or go inside the uterus. We line up our instruments in our setup space with the handles all on one side of the space and the intrauterine portions on the other side. And we never place our hands anywhere past the fulcrum of the instruments. The risk for injury to surrounding tissue when we're doing an intrauterine procedure is the risk of perforation, and we estimate that risk to be about 1 in 1,000. In some cases, the risk is from the instrument going through the fundus of the uterus. But when we're doing instrumentation of the non-pregnant uterus, we think about the curvature of the uterus being tilted forward. It's anteverted. And the instrument that we place in the uterus is going to go up through the cervix into the uterus. And if the uterus is really sharply curved, when we're trying to pass that device through the endocervical os, there can be a lot of pressure there and we have to get past that resistance. If the posterior uterine segment is quite flexed, we could think that we're pushing through the endocervical os and actually push through the posterior uterine segment instead and cause a perforation. In order to avoid that, we want to straighten the uterus out. And the way we do that is with a device called a tenaculum. This is the tenaculum. It looks like it's a torture device because if you think about this closing on your finger, that would be very painful. The cervix, however, is not innervated the same way that our finger is. Our skin, the perineum, and the distal third of the vagina come from ectoderm, so they are somatically innervated, and they would feel this as a sharp pain. However, the uterus, the cervix, and the proximal 2/3 of the vagina come from mesoderm, so they are viscerally innervated, and they do not feel discomfort the same way. So any manipulation we do of the cervix or uterus is felt by the patient as a deep uterine cramp, and it's generally tolerable. A lot of intrauterine procedures are very uncomfortable, but they can be done in the office without sedation. Using some ibuprofen about an hour beforehand is generally great. If we're going to do an endometrial biopsy, that's usually because somebody's having abnormal uterine bleeding. It might be someone after menopause who's had no bleeding for a year and now has started having bleeding again. Or it might be someone before menopause who's having very heavy, irregular periods. And what we're looking for is endometrial cancer. This figure gives a list of women who should be evaluated for the possibility of endometrial hyperplasia or endometrial cancer. The endometrial biopsy is a test that allows us to sample the lining of the uterus to look for hyperplasia. One common reason that we need to do an endometrial biopsy is when a woman has postmenopausal bleeding. So she has had no menses for 1 year and is officially menopausal and then develops uterine bleeding. This can be a sign of endometrial cancer. But you can see that there are also categories before menopause where there is abnormal bleeding that should be evaluated further. Sometimes that evaluation would start with a transvaginal ultrasound, which will help us assess the thickness of the lining of the uterus. Once that has been assessed, we can decide if an endometrial biopsy is needed. Sometimes we'll do the biopsy and then immediately place an IUD, a hormonal IUD, to help suppress the excessive menstrual bleeding. There are Pap tests where an endometrial biopsy is recommended. And we also do endometrial biopsies for screening in women with Lynch syndrome, also known as HNPCC, because they have a higher risk of endometrial cancer. Starting at age 30 and until they've had a hysterectomy for prevention of endometrial cancer, women with Lynch syndrome need to have an endometrial biopsy every year. We want to get a sample of the endometrium, and we use this pipelle to do that. The pipelle is a special syringe. It's long and thin so that it can go into the uterus. It has a little hole right at the tip, and the hole is on the side of the instrument. It's not at the end. So it is going to create suction and bring in material from the side, not from the end of the device. You can open it up to create the suction, but there's a stopper that prevents you from pulling the stylet out of the pipelle. Once we've placed this in the uterus and collected the suction, we're now going to have a sample that comes down the pipelle, and we can see that as a dark red tissue. We don't know where in the uterus that sample might be, so we need to rotate our pipelle and move it inward and outward so that we're sampling the entire endometrium. We don't want to move it back and forth like a windshield wiper, because then we would be missing half of the uterus, half of the endometrium on the other side. So we want to move it all the way around, more like a lighthouse. And at the same time, we're moving it in and out. So this ridiculous demonstration is showing you how we're moving the pipelle in and out while we're moving it around and around so that we sample the entire endometrium. I'm going to put this pipelle back together and walk you through the steps of the procedure. First, we place the speculum just like we would for a Pap test. This is the back of my hand. This is the muscle. I'd like you to relax. Cold gel and pressure on that muscle. This particular model has very non-compliant tissue here. So then we open that up and find the cervix. Now that we can see the cervix, we want to apply an antiseptic solution to help reduce the risk of infection. You can do that with one of these gynecologic swabs applied to the cervix after soaking in betadine, and we do that 3 times. You might also use gauze, which is very scratchy, so I don't really like to use gauze myself. If you do use gauze, you can fold it in thirds and then in half to make a narrow sponge. Which you can grip with the ring forceps. Depth perception here. And then use that dipped in betadine to soak the cervix with the betadine. And again, you would do that 3 times. After we've applied the antiseptic solution, we can apply the tenaculum to the cervix. You may see people place the tenaculum horizontally, or you may see them place it vertically. The horizontal placement goes on the anterior lip of the cervix, and we open the blades of the tenaculum wide, grip the top of the cervix, and then slowly close the tenaculum. And while I'm doing that, I'm talking to the patient about what's going on this weekend, what are your kids up to, what have you been doing in work, while I slowly close that over 10 seconds. Once I have the tenaculum on, I have control of this uterus. I can move it back and forth, and I can straighten it out. You may also see people place the tenaculum vertically. There's a few benefits to the vertical placement. With the vertical placement, one of the blades of the tenaculum actually goes into the cervical os. And again, I'm going to close the blades very slowly while counting to 10. So with the vertical placement, there's only one site that goes through the ectocervix that would bleed, because the site in the endocervix usually doesn't bleed quite as much. We have if the tenaculum does pull off of the cervix, it's easier to sew back together with a vertical stitch rather than trying to close the horizontal tear, though usually those tears don't need to be repaired at all. When we're getting our grip, sometimes it feels like you have a firmer grip if you're holding the tenaculum this vertical way rather than the horizontal way. Once you have the tenaculum placed, you can place the pipelle. So I'm now going to use my non-dominant hand to pull the tenaculum straight toward me. I'm trying to straighten the uterus. So I'm thinking of the vectors of force of the tenaculum and the pipelle as being parallel to each other but in opposite directions. So I'm going to pull the tenaculum toward me while I aim at the cervical os, and I'm now going to slowly pass the pipelle through that os. If I feel some resistance, I'm going to pull the tenaculum straight toward me more and straighten the uterus out better to help relieve that resistance. There often is a little resistance when you pass the internal os, and then once you can get past that, you just gently pass the pipelle in until you feel it stop. And I feel it stop right there. So if we look at this uterus, you can see that I've pushed the pipelle into a corner of the uterus. A uterus doesn't really have corners. This model has sort of a triangular shape. So the pipelle might be up here, but it might go into this corner. In an actual uterus, it's more like a cylindrical potential space. I'm now going to pull the handle of the pipelle, so I'm pulling out the stylet, and I just need to get it past the 10. I'm not sure if it's possible to see the 10 through the camera, but the pipelle is labeled and it has some fat markings at 4, 7, and 10. The reason it has a fat marking at 4 is that the cervix is about 4 centimeters in length. So if you haven't gotten past the 4, you haven't gotten all the way up to the fundus of the uterus. The 7 is a pretty typical sounding measurement, so usually 7 is about where we would go. And then 10 is a bigger uterus size. Once I've created that suction, I can now do my pulling in and out and my rotation. And if I'm meeting resistance, I can pull back on the tenaculum again to relieve that resistance while I'm pulling this in and out and rotating it around. And in an actual patient, I would see the sample come down into the pipelle. Once I've seen the sample come down, I'm going to remove the pipelle. I'll feel and hear the suction release. And then I can pass, if we imagine that I have a formalin jar right here, I can push this pipelle. They're very stiff, so you have to sort of push it from, you have to choke up and push it from right above the pipelle. And you push that sample into the pipelle, into the formalin solution. Then you repeat that process one more time to increase the sensitivity. And after you've done 2 passes, you take some scissors and you cut off the tip and you send the tip to pathology along with the endometrial sample. These are 2 examples of what an endometrial biopsy sample might look like. The sample on the left was collected from a patient in her late 40s who was having very heavy menstrual bleeding. We placed a hormonal IUD after this sample was collected and her bleeding improved significantly. The sample on the right is from a patient with Lynch syndrome who has an annual screen without any symptoms. You can see that the symptomatic patient's sample was much darker and redder, while the asymptomatic patient had very little pigmentation to the sample. Both samples maintain the worm-like shape of the pipelle, which tells us that we have histology for the path lab to look at rather than just cytology or cells floating in fluid.